just wanted to thank everyone for taking some time out. I know it's a beautiful evening to come here for the live event. And then we'd also like to thank all those who are going to be tuning in as well for taking some time out in their evening to kind of learn a little bit about obesity, about some treatment options for obesity, and about bariatric surgery and what we have to offer here at Premier Health and Premier Weight Loss Solutions. Our main office is located in Centerville, and then we have office actually on the north side at Miami Valley North, and then we do operations both downtown at Miami Valley Hospital, and we're actually going to start doing some operations at Atrium Hospital as well. So I'm Dr. Adam Golas. I actually moved to the Dayton area last year and took the job as the bariatric surgery program medical director. So I actually am originally a Hoosier, so hopefully everybody will continue to stay here, all the Buckeyes, but we can play nice in the sandbox together. But a Hoosier, grew up in Southern Indiana, and I went to IU for undergrad and also did my medical degree at Indiana University. And then after I finished my medical degree, I did a Master's of Public Health as well. I went down to University of South Florida in Tampa, where I did general surgery training and then followed by a bariatric minimally invasive surgery fellowship. And then after finishing that training, I went back home to Indiana, where I was in private practice, where I did both general surgery and bariatric surgery for a little over 3 years prior to making my way here, taking a promotion as the medical director here. So, you know, more than 30% of the industrialized world is affected by obesity. And that's actually where patients have a BMI once it's above 30, right? Over 100 million Americans are affected by this disease, more than basically a third of the country, right? And nearly 1 in every 2 Buckeyes. So it's actually even more prevalent in the Midwest. It's actually roughly 42% of folks in the area that are affected by this disease. And 25 million Americans plus, actually, and probably much more than we think, because we've seen a lot of patients on average gain anywhere from 20 to 40 pounds since the pandemic kind of set in and changed a lot of lifestyles. And it's very costly, not only for the healthcare system in general, but also for the patients. And that has to do with some situations which it changes patients' lifestyles, costs for their healthcare, co-pays, things of that nature we'll talk more about. And something else has grown in this time frame, has exploded over those 20 years. Does anybody have any idea what that is? Processed foods, fast foods, right? I mean, when was, changing the way we eat, processed beverages, right? So here we are in basically 2000. So it's roughly, 20% here in the Midwest, right? So then as we progress, now you start to see down there in the, southeastern portion of like Louisiana area, now 25% as it becomes red. 2003, we're going forward, 2004. More, kind of spreading throughout the southeastern portion of the country. Now we've got states coming in at 25 to 29% in the, 2006, 2007. And I think this data goes on to, as we kind of fast forward here, I believe to 2011 when this was stopped being tracked. Let's kind of get there. But we'll see, you can see that it's just really exploding, particularly in the southeastern portion of the country, in the Midwest, but then throughout the entire country for that matter. They're just kind of lagging a little behind on the West Coast. But as you can see, by year 2010, roughly Midwest, well over 30%. So you may ask yourself, well, can it get any worse than that, right? Over the last 10 years, what has it done? Well, I guess I kind of gave it away a little earlier. Unfortunately, it can get a lot worse. And again, we think it's probably a lot worse than what we even know because we haven't started really getting a census on it or tracking the data with COVID. But, the prevalence, now is basically 42% in 2017, 2018 prior to COVID, right? And so that's a 20% increase since basically 1999 and 2000, right? A full twofold increase. So it was 20% previously, and now it's 42%. It's doubled, right? And so with that expectation, at this rate, by the time, my later years throughout my entire life, maybe when I'm near death, we're talking, this could be roughly 80% greater than 80% of the population suffering from obesity with a BMI above 30. So I don't mean Wally may not have been very far off if we don't have some changes in kind of the way we live and have a food industry that's more responsible to our patients and our society in general. So a lot of things that people don't realize is obesity is a disease, right? And society, there's a lot of stigmas that society places on our patients. And yes, there's a lot of popular shows like that, My 600-Pound Life, but that's not our everyday patient by any means, right? A majority of our patients, are just everyday people, moms, living just like everyone else who have a low basal metabolic rate, but who are exposed to a Western culture, right? In a way, the way I look at it sometimes, it's almost as if we live, when it comes to how we live in Western cultures, where it's fast-paced, there's a lot going on, a lot on your schedules, very difficult to find time to exercise, especially our moms. I mean, our moms are kind of keeping the homes down. A lot of our moms are working full-time job, if not 2 jobs, right? They can't find the time to get out and exercise. The foods, as far as processed foods, are much more affordable. They're a lot cheaper. They're super calorie dense, but generally they're poorly nutritious, right? You look at the grocery stores, they're just packed with processed foods, right? You ever heard that you should just kind of shop on the periphery? God intended us to eat what grows in the dirt or walks on the dirt, right? But the grocery stores are just packed with processed foods. And when I talk about this whole idiocracy of things, so imagine a patient who falls on the, a couple standard deviations away from the mean as far as their basal metabolic rate. Yeah, we have the people, the outliers on the other side who can eat anything and not gain any weight, right? Well, 1,000 years ago, those people wouldn't survive, right? Their just metabolism's too high, and we've grown up for the most part through famine. But then you look at the people on the opposite end of the spectrum with a very low basal metabolic rate who have genetics that are to the advantage of, you could say, the species, or they're more fine-tuned. A calorie doesn't mean the same to them. They're like a Tesla compared to like a Hemi Dodge Ram. They can just get by with less. Well, in a Western culture, the cards are really kind of stacked against them. When you can go out and get a meal and get more than your daily caloric needs, overeat, and not feel stuffed, and still have many food left for lunch the following day or dinner the following evening, right? And when you think about the idiocracy of it, if like, these carbs and things we have at our disposal, like chips, anything, all these snack foods and things, or Cheez-Its, if they fell from trees like leaves, right? And we had soda pop just running down creeks, it would actually be harder to get it than it is right now, the way we live, right? With fast food restaurants on every corner, it seems. Uber Eats delivering them to your doorstep now, right? Gas stations, vending machines everywhere. It just seems that you just can't get away from it, and it's all very cheap and affordable, right? So it's a very big challenge, and especially for our patients who have BMIs on that lower end of the spectrum. And early on with the morbid obesity rates, it was very similar to the fact where you would expect patients to fall based on having those low basal metabolic rates. And unfortunately, there's a lot of secondary healthcare issues that patients can develop from this obesity and this disease process. And the way you want to look at this as, well, how do these diseases come about? And the way to kind of look at it in a general sense and the big picture of things, where how disease comes on with obesity. When patients start to gain this weight from having these super out of balance diets, because their bodies are very efficient, that excess adipose tissue starts to change the physiology in the body. As you build up more adipose tissue and it starts to accumulate, what happens, you kind of develop this sea of fat. And so the body is a bunch of different cells, and they communicate particularly through hormonal signaling to perform in functions for normal, healthy physiology, right? So as you accumulate more and more adipose tissue, the disease starts to set in. First off, where the metabolic rate really gets thrown out of whack, and the body really kind of trying to reset itself, makes it very challenging over time. Once that BMI hits above 35 mark, it becomes very challenging for patients to lose the weight on their own, right? That physiology's changed. But let's say, for example, one thing that's very common in our patient population, polycystic ovarian syndrome, menstrual irregularity, right? Infertility issues. So the ovaries, when they secrete, when they release the egg, and then this corpus luteum is supposed to be starting to develop and communicating with the uterus, so that when that egg makes its way to the fallopian tube down into the uterus and needs the implant, there's a lot of communication that occurs between the ovary and the uterus. And so when the ovaries are secreting its hormones into the bloodstream, which the end target is the uterus, that hormonal signaling gets disrupted. You know, some of it gets absorbed in the sea of fat, in the sea of adipose tissue. And when those hormones get absorbed in the adipose tissue, then the adipose tissue will release the hormones at its own basal rate. And so then it disrupts the signaling between the ovaries and the uterus. It's just a broad picture of it. And then it disrupts the ability for that to go as would be planned, right? And so it's not surprising that when patients become morbidly obese, that they start to have challenges with their menstrual cycles, with PCOS, with fertility issues potentially, right? Or even maintaining the pregnancy once they are pregnant. And it's also not surprising then when they lose a majority of the weight, 70, 80% plus of that excess body weight, that they actually, a lot of these issues, if not all of them, resolve because you got rid of that sea of fat. It's now a better signal between the ovaries and the uterus. It's like going from T-Mobile, you know, being on the Verizon network. Are you there? Can you hear me now? Right? So it's impressive. Same thing with like hypertension, hormonal signaling that occurs, diabetes, insulin resistance. The beta cells are pumping out additional insulin because the insulin's being absorbed in that sea of fat, then being released. You get insulin resistance. Same picture potentially when you look at it from a broad perspective. And you get these secondary conditions, like the big ones are hypertension, high blood pressure, hyperlipidemia or high cholesterol, diabetes, right, with disruptions of the sugar signaling with insulin, insulin resistance, obstructive sleep apnea, airway disease in our patients, right? That's one that we'll screen for quite frequently in our patient population, and we'll talk a little bit about why that's important here in the future of the presentation. And there's many others that we'll go over. And unfortunately, so this disease, as a lot of our patients have realized, it's progressive and lifelong, right? It almost seems as if you continue to kind of gain weight, and you'll have some success. Like you'll get in a regimen, you'll get doing a lot of diet and exercises, and you may lose 20 to 50 pounds. Then a stressor will hit, maybe a death in the family. You lose your job, or your spouse loses your job. Big stressor changes your whole pattern. You kind of fall out of the discipline regimen you're in this Western culture, and it seems as if you gain the weight back almost exponentially, right? And you almost didn't miss a beat if you were trending yourself, right? You drop, gain it back, and then continue to gain a similar rate. And if that's what you've experienced, that's certainly you're not alone, and that's what a majority of our patients are seeing. And unfortunately, this disease is life-threatening if it progresses. You know, a lot of our patients, they're not coming here seeking help for concerns, cosmetic concerns, or issues with willpower, as you may see. Like, you know, there's some low-hanging fruit on my 600-pound life in some of these patients, where once they have situations where their BMIs are getting 80, 90 plus, they're coping with food. You know, they have some psychological challenges that they're doing to cope with some depression, and their comfort is food in that situation. But again, and all of us do that sometimes. I mean, I can be a stress eater. I have some tough cases, you know, and, you know, a long day in the OR. My wife, I'll come home and she'll catch me, and I'll just be kind of snacking and eating around, and she's making dinner. She's got to stop me. It's so easy to do. And gosh, I mean, I'm obese myself. My BMI is 31, right? I have 2 twin toddlers. I have an infant at home. I'm a surgeon. There's just a lot going on. I haven't been able to exercise as much. I'm trying to get back in their routine. When I'm on it, I'm usually a BMI of 28, 29. I'm on a little bit of the higher end, but for men, we have a little more muscle mass, so it kind of will be inflated by a point or two. But based off the BMI criteria, I am currently obese. And for our patients, this really isn't, again, a problem with willpower, because it's, again, I think it has a lot to do with, our exposure in our environment. And it's not a character flaw. And as everybody, I think, in this room and anybody viewing would probably agree that it's not easily treated with diet and exercise alone. So unfortunately, as we talked about, obesity, unfortunately, is killing patients, right? It's certainly the second leading cause of preventable death in the United States, second to only smoking. And it's close, and over time it may surpass that as less and less people smoke. Hopefully people will quit smoking. It's certainly something that's preventable, but at the same time, hopefully we can make an impact so that never happens. I mean, it's estimated that at least 325,000 people die per year unnecessarily secondary to obesity. And that's probably a conservative figure, right? That's more people, I think, than live in Montgomery County, I believe, or close to it. So what is obesity? You may be wondering or asking yourself. So obesity is a point at which, someone's weight or their obesity is severe enough to where you start to develop, secondary health conditions, right? For the morbid obese category. Or we define it as a BMI above 40 just in any patient, because it's just a matter of time at that point before you may develop an obesity-associated comorbidity like hyperlipidemia or cholesterol issues or diabetes or high blood pressure or sleep apnea and so forth. But any patient with a BMI above 35 who has some of those conditions, and most bariatric surgeons and metabolic folks would agree that anybody even BMI above 30 who has those conditions would be considered in that category as well. So what's a healthy BMI? It's healthy, they say, is 20 to 25. I kind of feel, and I don't know if Anne would agree, but I feel like in a Western culture, you're shooting for about 25 to 28. Let's be realistic. Again, environmental exposures here, right? So I really think that's where we're really shooting for, and we really do a great job of getting our patients there. I guess I should say actually our patients do a great job of getting there after we give them a tool. And overweight is considered when that BMI, just for definitions, is above 25. Obese is when it's above 30. And then morbidly obese is once it's above 40. And it looks like our graph didn't come in here. So what this was, I'm sorry it didn't show up. It's just a graph. You can Google search it. It's pretty standard. It's a graph that shows how to calculate your BMI just by your height and your weight, right? There's also calculators online. If you want to calculate your own BMI, you just need your height and your weight. And what body mass index is it's basically just a way to standardize everyone in order to compare maybe how overweight someone may be, but you have to take into account, of course, how tall they are, right? Because someone who's like 5'2" is going to be a different BMI, or if you're trying to compare the two of them with being a level of being overweight to someone who's 6'4". But either way, it's just a marker that we use. So, and it takes body surface area into consideration. Sorry about the fast forward there. So some risks for obesity. So just when the BMI just becomes just above 30, right? Patients have 55% increased risk in mortality already, and that's all comers. That means, of course, someone who's the age of 36 may have a mortality risk of just under a percent a year or something of that nature. Don't know exactly. Don't quote me on that. Don't know exactly. 1.2%. I don't know. Or somebody who's 68, their mortality rate may be somewhere around 10, 12, 14%. But it doubles once that BMI is about 35. So let's say someone who's 68, and let's say it's 14%. This is, again, just throwing out a number. That means their actual risk mortality would be close to 28% if their BMI was above 30. 70% increased risk of heart disease. 75% increased risk of stroke. And this stroke phenomenon occurs because patients become hypercoagulable, because the adipose tissue in and of itself creates a hyperinflammatory state within the body. There's a lot of cytokines, inflammatory mediators that continue to accumulate as we accumulate more adipose tissue. Diabetes, 400% risk, fourfold increase just with the BMI only above 30. These all increase as the BMI goes up, right? So these are conservative figures compared with patients who suffer from morbid obesity. Once the BMI is above 50, there's a 10-fold increased risk of death when compared to their counterparts with a BMI of less than 30, right? That's a huge difference there. And to the point where, if a patient is morbidly obese, so a BMI above 40, only 1 in 3 statistically would live to see the age of 65 or above, right? You don't see a lot of frail obese patients out there. Patients who live in their 70s, 80s, 90s, these patients are usually fairly thin and frail, right? So obesity-related comorbidities are these conditions that can come on with the onset of this disease. A big one, of course, is diabetes, very common in the patient population. High blood pressure we talked about, high cholesterol. We've got, I think I have a pointer on here, sorry, cardiac disease. Another big one is a respiratory disease, particularly sleep apnea. Now, asthma in patients who are obese is always going to be a lot worse in an obese patient. If a patient kind of lose the weight, a lot of times their asthma can go into remission. But a lot of our patients who have asthma had childhood onset asthma that's continued because, again, this hyperinflammatory state that occurs in the body that causes the inflammation of the bronchioles that causes those to constrict. But a big one that we really look for and test for is a respiratory disease called obstructive sleep apnea. So what happens with obstructive sleep apnea is the airway will kind of partially collapse on the patient when they're sleeping, right? And when the airway collapses, they're not ventilating as well as they should. And the patient actually will stop breathing for some time because they get used to their CO2 levels going higher. And initially, it's the CO2 levels increasing that drive your ability to take a breath when you're no longer awake and you're asleep, right? You're not consciously controlling your breathing. It's a subconscious control. So patients who have sleep apnea that's untreated, there's 4 stages of sleep, right? They'll kind of go down to stage 2 and 3 sleep. Okay? And their body's in a way staying subconsciously awake to keep their airway open, to finally blow that CO2 off and oxygenate, right? They don't get down to the stage 4 restorative sleep, the REM sleep, very often. So these patients are chronically fatigued. They're exhausted. They feel like they never got a good night's rest. Just identifying the sleep apnea itself and treating it is going to profoundly change that patient's life, right? It's probably contributing to their obesity as well because they're just not as active, because they're exhausted, right? So it kind of compounds itself. So we do a thing called a stop-bang assessment on all of our patients who aren't already diagnosed and being treated, because another thing that's really important about sleep apnea, and you'll see how, we'll talk about how safe bariatric surgery is now, is if you can find it and treat it for a good 4 to 6 weeks prior to surgery, it recruits the lungs up well, it gets the patient into better health from both a cardio and pulmonary perspective, that it actually significantly decreases your risk of a cardiopulmonary complication after the surgery, right? Because patients who have sudden death from sleep apnea, these are usually undiagnosed patients. They may have a party, New Year's or a birthday party, or have a toothache and got put on an opiate, drank too much alcohol, went to sleep, and did not stay subconsciously awake and just never woke up, right? But after surgery, you're recovering from an anesthesia. We treat your pain sometimes with some narcotics and things of that nature. So it's important to make sure we have that treated and have you on a CPAP on recovery. Then it decreases your risk of CO2 accumulation and a cardiac event and a code that could occur, or a respiratory code where a patient stops bleeding, we have to establish an airway and things of that nature. Okay? So it's just one of the things that we do in our workup that you'll learn to help make this operation safer for you. Osteoarthritis is very common in our patient population, particularly in the knees and the ankles and even in the lower back. Depression is terribly common. I think it has a lot to do with the lifestyle limitations that it has and also the stigmas that society placed upon our patients. The good news is those all improve with the weight loss. Stress incontinence, increased abdominal obesity, increased pressure in the abdomen, increased incontinence issues, increased reflux problems, and menstrual irregularity, as we kind of discussed. So, sorry, another formatting issue here, but that's okay. So conventional methods for weight loss, we of course know diet, exercise. We have a medically supervised weight loss program. We also use medications within that program. So traditional diet and exercise, patients can expect maybe most patients will report on average 5 to 25 pounds at home, kind of working on their own, where we talked about the cycle that a lot of people experience. They'll lose it, stressor, life event, change of a job, and they gain the weight back quite quickly. Medically supervised weight loss programs with medications, a structured team, can have a lot more success. Anywhere from 30, 50 pounds. But some of our patients, the outliers, this is average, 30 to 50 pounds. But the outliers, we have patients that can lose well over 100 pounds in those programs, right? And we know that about 5% of the patients, looking at the literature, shows once their BMI is above 35, can kind of lose the weight and keep it off on their own. And over a majority really struggle, and again, I think it's environmental. Surgery, what we expect to see, in the first 6 months, patients will lose about anywhere from like 30 to 50% of their excess body weight typically in that first 6 months. Around the 12 months mark, on average, patients can reach upwards of 60 to 77% excess body weight loss. 18 months, patients who are really buying in to everything they're learning, they're basically in a medically supervised weight loss program and surgery, really buying in everything they're learning from our team, they can lose well over 80 to 90% of their excess body weight. And the good thing about that is it also leads to resolution of a lot of their comorbidities, which we'll discuss briefly too shortly. So you may be hearing this and you think, wow, that's amazing. This seems almost like magic. And it seems that way the first year and a half. It's kind of like a honeymoon phase, the 1.5 to 2 year mark, right? It just seems a lot easier than what you would expect. But you got to understand that it's not a cure, and it should really be looked at as a catalyst, right? A way to kind of reset things, okay? To where you'll lose upwards of 70, we talked 70, 80% of this excess body weight, help reestablish a normal physiology where all this hormonal signaling is happening effectively, feel generally way healthier. Hopefully a lot of your comorbidities are into remission. You've exchanged your antihypertensive medications and your diabetic medications and your statins and things for just vitamins and protein supplements, right? That's the goal. But you got to understand it's a catalyst, and you have to buy into this is a lifelong process, right? So we're looking at, most of our patients are seeing us when they're kind of in the early phase or in the mid phase of the second half of their life. It's when we realize we're not invincible, right? And you'll have a lot of success, but you really have to buy in. It's a lifelong commitment to yourself and to a program like ours, where we'll see you initially early on quite frequently the first couple of years as we're bringing you through this journey. And then you'll always see our program annually thereafter, where you'll see the dietitian, and you'll see myself, or you may see Dr. Wang, or you may see one of the bariatric physician assistants, Ann Kroger, Tori Sorice, and we'll continue to work with you, right, to make sure we're staying on track, we're not falling off track, we're not having weight regain that we need to address, but also managing and following some of our electrolytes, our vitamin levels, things of that nature, also looking at our protein levels, and then also looking for some rare complications and intervening and working these up before they can become bigger problems. So, in Einstein, one of his famous quotes was, insanity is doing the same thing over and over again and expecting a different result. And just changing your general lifestyle in regards to becoming more active as you lose the weight to make sure you can maintain this weight loss indefinitely. So different diet, different lifestyle means different body, hopefully, until the end of your days, right? So you may be asking if you're a surgical candidate. And so, the NIH consensus criteria, which most insurance companies will follow, Medicare, Medicaid certainly do. Anybody with a BMI above 40 is considered a candidate for bariatric surgery. Because if you don't have one of the comorbidities, it's just a matter of time before they come on. And then a BMI of greater than 35 usually requires at least one significant comorbidities for a lot of insurances. Now, some don't require it, a few. And I don't really think they should at that level, maybe above 30, but most really still do. And these are like high blood pressure, cholesterol issues, diabetes, sleep apnea, and some accept a few others. Failure to lose weight in a supervised exercise program, this is mostly fallen out of favor. There are some insurances, few stragglers that still require this. Now really what it's become is a good 3 to 6 month medically supervised weight loss program for a lot of insurances, where we have you work with our dietitians, the surgeon, the bariatric physician assistants. You'll see a psychologist in our programs that kind of help prepare you for what's to come. Because again, we're looking at the second half of your life, not just the next 1.5 years. Okay, we're looking at maintenance of weight loss too, right? Compliance with a multidisciplinary program. Again, in our program, the way we have it set up, as the surgeon, I'm not the primary decision maker if you go to the operating room, right? It's a team-based effort, and the patients are part of that team. So there's 5 people involved, right? The surgeon, the dietitians, the bariatric physician assistants, the patient, and the psychologist, right? And everybody wants to be on board to make sure we think we're doing the right thing for you and you're at a right place to move forward with an operation, right? And if patients are kind of not there quite with one of those, we work with you and get you there, okay? But everybody's got to be on board, including the patient, that we're ready to proceed. Ability for lifelong follow-up is very important. That's something else we kind of will judge sometimes just with, patients being able to reasonably make their visits. There's a fair number of visits over the 3 to 6 months. So if you find that you're not able to make literally any of your first visits you continue to reschedule, you may want to ask yourself, is this the right time in your life, right? Because you're going to need to follow up quite frequently early on after the operation. We do basically a 2-week follow-up after surgery, then it's a 6-week, then it's a 3-month, then it's a 6-month from surgery, then it's a 9-month, then an annual, then 18-month, right? So with labs and things, we're kind of tweaking things at that point. So really important for you to make sure you think you're ready. Now, women of childbearing age, it's really important. I know a lot of the women come to us of this age, and one primary factor of them coming is they're having issues with PCOS, infertility, menstrual irregularities, and they also maybe hope to bear a child at some point. That's fantastic, and that's a goal of ours, but not for the first 18 months, because it's not a great environment for the developing fetus early on. There's a lot of changes in the physiology of the body, how you're digesting, dealing with all this fat. Not a great environment for the fetus. And it's also going to hamper your results if that were to happen, if a patient were to become pregnant as far as what weight they may lose. It's key that first 12 to 18 months to get the best you can out of this catalyst, and then from there, preserve it, right? So this is just a quick little diagram of the GI tract. So just a quick little refresher here from some of y'all back to maybe high school when you had this. Number 1's the esophagus. You know, that's where you eat your food, comes down your esophagus, plugs into your stomach here, number 3. Then you have this is the pylorus, the little sphincter here that allows food to come out of your stomach into your duodenum here, number 5. You can see your pancreas is very intimately associated with both the stomach and the duodenum here. And so then the duodenum becomes the jejunum right about here. The duodenum is a short segment, but very important. And then the jejunum is here, number 6. It's about half your bowel length to about here. Then that becomes the ileum. It's the other half of your bowel length, number 7. And then that plugs into your colon here, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, anus, and that's where you would have your bowel movements, of course. So that's your GI anatomy. So this next one here is just kind of a video that shows you one of our operations, and we'll talk a little bit about it afterwards. I'll let it play if it works. This is a video depicting the Roux-en-Y gastric bypass surgery. Here you'll see where multiple small incisions were made, where we insert trocars in order to get the surgical instruments to access the abdominal cavity from a minimally invasive approach. Here's the intra-abdominal anatomy, and we'll zoom in here on the proximal portion of the stomach, where we use a special stapler device to form a small gastric pouch the size of a large egg. Then we go down to the small bowel, distal to the duodenum, and divide the bowel. And then we bring the distal portion of the bowel back up to the stomach pouch to create a conduit from the pouch down to what we call the common channel. Then lower, we form another anastomosis between the biliopancreatic limb, the more proximal bowel that was earlier divided, to the roux limb, and as you can see, the digestive juices then mix with the food, and food is absorbed there further. And what the video started to show patients was that we use these small little incisions, okay, to do this procedure. I do a total of 6 small incisions. So my camera incision is about 15 centimeters below the xiphoid, 5 centimeters to the left perimedium position right here. It's just about this big, right here. Then there are 2 assist trocars here and here. And then there are 2 surgeon trocars here and here. These are small, about this big, either a ½ centimeter or 1.2 centimeters. And then there's a little liver retractor on the far right side. But all tiny little trocars. Incisions. And we put these trocars in that help maintain the incisions, and we insufflate the belly up. And they have little valves in them to keep the air from coming out. So we make your abdomen this dome, right? And then we use these longer instruments to go in and do the operation. So what that showed on that video is that with the bypass, what we do is, the first thing we actually do is we divide your bowel more distally. This portion was attached to here. Well, we kind of measure it all out and we'll divide it. And then we take the end that was down here and bring it up here. Later, we're going to sew it to this pouch. We just kind of set it to the side. Then we measure this out to be about 1/3 of your bowel length, anywhere from 100 centimeters to 150 centimeters. And then we basically sew these back together so that, now the old stomach called the excluded stomach has now been bypassed, and the duodenum has been bypassed. So this is the bypass procedure. But it has all the digestive juices, right? So the stomach makes some acid. Inside the duodenum, there's there's a duct here that plugs in from the pancreas and the liver, where you get your bile, your enzymes digest proteins, carbs, things of that nature. So they got to get back to where they help you digest your food. So we sew this bowel back here. It's called the jejunojejunostomy. And then from there forward, about 2/3 of your bowel length left. That's where you now absorb your nutrition. So this operation, what it essentially does is it makes you eat much less. So it creates a small pouch here. And of course, your small bowel plugs into that. So you'll kind of fill up a similar size to about a sleeve, you'll see in a minute. But it's a restriction in a way that just makes you be satisfied sooner and eat much less, right? In a way, in my opinion, the way I like to look at it is, it's a tool that kind of gets you to eat more of what God may have intended you to eat, right? Because you're able to eat, you eat much less because you're just satisfied sooner. If you watch the show, anybody watch the show Alone, and you see people on that show, they put 10 candidates, and they get to bring 10 anything modern survival tools, and they all try to survive as long as they can. And you'll see, they're like hunting, they're back to hunters and gatherers, what we were in our roots. They're hunting some berries, they find some mushrooms maybe, they get some small game, catch a little mouse or a rabbit or something, but I can assure you it'd barely fill that anatomy, right? And they do that about 3 or 4 times a day, which is kind of what we were intended to do. So I feel that's one reason. So you're restricted to eat less, so you lose a significant amount of weight. But then also, you bypass that excluded stomach and that duodenum, but also this roux limb here, this portion that's, again, about 1/3 of your bowel length, it's really just more of a conduit, like a pipe, to get the food from here down to where it's actually going to be absorbed. It's malabsorptive as well, this procedure. About 1/3 of your bowel length, or even more, depending on how far we make that length based on the weight, isn't contributing to absorption. There's not really much here to absorb. There's a little amylase from your saliva, but there's not all the enzymes. The food's mostly macro, and the absorption doesn't start happening until down here. So very, very successful operation for weight loss. 20 years of data behind it. It's considered the gold standard operation in general for bariatrics. It's just withstood the test of time. It's a great operation for reflux. Reflux is most commonly caused by bile reflux, or then acid, of course, coming out the esophagus. Well, when you change this anatomy, the acid from the stomach and the bile come down. When they plug in down here, the chances of them refluxing all the way up 1/3 of that roux limb, and it's longer than this really shows, this is just to make it easy to see. But the chance of it going up this way, when this bowel was made by God to move fluid in this direction, the chance of it going backwards is extremely low. So it essentially cures reflux, right? So great operation for patients who have reflux. Diabetes-wise, phenomenal what results of what it does. Remember that intimate relationship with the pancreas and the duodenum here? There's a lot of medications that are made based on this relationship, like GLP-1 inhibitors, glucagon-like peptide inhibitors and things. Well, when we bypass, the food never sees the duodenum. There's some physiology there we still don't quite completely understand. Almost early on resolution of diabetes, especially if that diabetes in onset has been almost less than 8 years. Really phenomenal. So not uncommon for us to stop all the patients' diabetes medications after the operation, and for them to go home with fairly normal blood sugars. Some of the cons patients would say is malabsorptive issues from vitamins and protein deficiencies, right? This can certainly be a con for a patient who has a hard time being compliant with some recommendations, like you're going to need a protein supplement the rest of your life after this operation, be it a shake in the morning, because you shouldn't be skipping breakfast anyhow, or maybe a protein bar. Profile you're looking for is 20 to 30 grams, less than 200 calories roughly. The team will help you kind of make some selections there if you decide. And if you take your vitamins daily, if you do those things, this wouldn't really be a con, and you should be looking at it as you're trading your medications for vitamins and protein. Some other cons are some of the late complications that can occur. They're rare, but they still occur. A risk of a bowel obstruction. After any abdominal operation, you can have some adhesions, can cause obstructions in your bowels. With the bypass particularly though, when we reroute the bowel, it's like a sheet of fatty tissue with blood vessels in it. And we do close these defects, especially this particular defect, But over time, when you lose a lot of weight, the sheet's made out of fat tissue. So you can form a small little hole, like a small hole in the sheet on your bed. And over a few years, as the bowels and everything are fluid and moving around in there, that small hole will slowly become a little bit of a bigger hole. And then bowel can go in and out of that hole and can cause symptoms of some pain, bloating here and there, comes back out, goes away. And in rare cases, the bowel can get in there and get stuck, cause a lot of pain, lack of blood flow to that bowel, and that's more of an emergency we have to correct. It's a low risk, but it's a risk. And it's another reason most patients who have what's called an internal hernia will have this waxing and waning abdominal pain and bloating, the 5% or less who have it. And you'll catch it. A bariatric surgeon, a bariatric physician assistant, they'll catch that, get a CT scan a lot of times, catch it on imaging, or just take it to the OR and do an exploratory operation and find it and close it. But just one example of why lifelong follow-up is important when you change your anatomy. So this next one was the sleeve gastrectomy. I'm sorry it wasn't working either.
The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
Again, same trocars. It's the same trocar profile for my operations. Dr. Wang, I think hers are pretty close as well for the sleeve or the bypass. But the difference here is that what we do actually, rather than do any like rerouting of the bowel, what we simply do here is we free up the greater curve of the stomach. We basically essentially excise about 80 to 90% of the functional stomach as far as the portion that can really stretch out close to the size of a football, the reservoir portion. What we leave behind is the lesser curve. So we take down these blood vessels with a blood vessel sealer that then kind of ligates them and divides them, and we get real careful up here because there's the spleen and short gastrics, and we want to get fairly close to this region. And this is where you get a difference from somebody who dabbles in bariatrics and a real bariatric surgeon. Up here, you really got to take some care to really get here and make this nice and floppy and get it to lift off the croup. And that's where a really good surgeon gets, and they don't go too far. So you put in a bougie device to maintain the lumen of the stomach, and then you use a special stapler that puts 3 rows on each side, basically triple ligates and seals, and then it cuts in between, and then with 5, 6 fires or so, you'll divide that portion off. Then this portion of the stomach, it's gone. It goes into a bucket to the pathology lab. And your new stomach is now about the size of a large garden hose or maybe a small banana. And then this again is a great tool in a Western culture to eat more appropriate sizes for meals. And patients have significant weight loss with this smaller stomach. It's a smaller stomach, rapid weight loss for these patients. There's no malabsorption. That's a big pro in respect to the sleeve, although it still changes how certain vitamins can be absorbed and processed, so you still need a bariatric vitamin for this procedure after the fact. And then there's also a hormone called ghrelin that's made in the stomach cells. This is an appetite hormone. It goes way down, especially the early phase, the first year to year and a half. Body adapts to a lot of things over time. It'll come back up in the cells that remain to counteract, but first it's a huge advantage that first year and a half. Some patients say, they're just not really hungry at all usually. They don't have the appetite they used to have early on. And they kind of eat because they know they need to get their protein and their hydration. Of course, over time, you build up more ghrelin, you get more of somewhat of a normal appetite, right? So don't feel like you're not ever gonna have an appetite again afterwards. Trust me, it'll come back. But what you can notice about these operations, and so I'll briefly talk about some of the risks here or cons. Some patients can have some nausea and vomiting after the sleeve. It's a big operation on the stomach, and some of this nausea is preserved centrally in your brain, so it's a little bit of a shock to the body. It's early on. It's usually treated pretty well with some Zofran here and there, and it gets much better with time. Sometimes patients with that nausea, they can get dehydrated, and you may need some infusions here and there after the operation. Less than, I'd say 10%, would you agree, Ann? But you know, it's not uncommon for 1 out of 10 patients to need to go to the hospital for a couple weeks of infusions after the operation, and then you'll get them through it. Leak risk is about 1%. The leak from the staple line here, you know, our goal is to get everything to heal and seal, but there is a small risk of a leak that can occur here, and that could require another operation if that were to occur, where you go in, wash it out, place a drain. On occasions, it has to be converted to like a bypass, for example, to get it to heal on a rare occasion. It's something that can happen, just we make patients aware of. Rare, but still happen. So you may be asking briefly, how well does this surgery work in respect to weight loss? We'll go over weight loss, comorbidity, lifestyle, safety, and some side effects and complications briefly. Man, these slides really got out of whack. Sorry about that. So this slide here basically showed a graph where this graph basically was, let's say that this is 0, and then over 1 to 2 years, the first 2 years it's exponential. So let's say over here this was excess body weight loss, and this was time the first year to 2. Patients are going to lose exponentially amount of weight in that first 12 to 18 months to 2 years. Again, anywhere upwards of 60, 70, 80, 90% of their excess body weight. And then the patients will kind of plateau up here at around that 80%, 70% excess body weight loss. And so that's about 70% of the patients. And 10% will continue to lose weight upwards of 90+% excess body weight loss. Patients who are really embracing the lifestyle modifications, the dietary modifications. But then some patients at that 2-year mark is where the magic kind of sets in. They may have some weight regain and then plateau down here. Maybe they'll gain back 30, 40% of what they lost. So that's another reason it's important to follow up in the program. We can catch that early on and prevent that from happening, okay? With both of those operations, you'd see you're restricted, right? So when you sit down and eat a normal meal size or a normal bariatric meal size, you'll feel full, you'll be done. But if a patient gets into some behaviors that are very common in a Western culture, sweet beverages, processed beverages, that are super high in calories, well, that's like a little funnel. It doesn't matter how tight it is. You pour it through, it's going to go through, right? You can't restrict those things. Grazing and snacking throughout the day consistently, putting yourself on a constant infusion of calories, you'll get a significant amount in, more than you would think over the course of the day, so you can have weight regain. So these are things we have to work on, catch, nip them in the butt when they occur. They'll come, they'll go. This one, diabetes, of course. We see 82 to 90% plus resolution at that 6 months to a year mark. Very, very effective for diabetes. High blood pressure, 62 to 70% of patients come off their blood pressure medications after the operation. High cholesterol, 63% resolved, getting off the statin. Sleep apnea, almost all the patients will get off their CPAP. Very uncommon for a patient to have to continue their CPAP after 6 months. Gastroesophageal reflux disease, 72 to 95% resolution, higher in the bypass than the sleep. One risk for the sleep group, which we didn't discuss, but I'll briefly bring up, is if a patient has bad reflux and you're taking Nexium or omeprazole twice a day, and you're finding that you're having breakthrough symptoms that requires a Tums, Pepcid, you may want to consider the bypass over the sleeve, because the sleeve can actually, in those patients, cause the reflux to become worse. It's rare, but it's still a possibility, because you take the compartment and you make the diameter much smaller, and with Laplace's law, the pressure in that compartment goes up exponentially, right? So something to think about. We can talk about more if you decide to come in for a consult. Metabolic syndrome, 80% resolution, okay? Asthma, 69%. Remember we talked about how asthma worsened by the hyperinflammatory mediators of the adipose tissue? Osteoarthritis, 41% resolved. But remember, a lot of these patients have joint issues. Bone on bone, a lot of loss of cartilage. But guess what? Once your BMI is below 40, it's much safer to get a knee replacement or a joint replacement. Much lower risk of infection and failure of such joint. To the point where some insurances won't even allow you to have a joint replaced until your BMI is lower than 40. And Medicare and Medicaid's kind of moving in that direction as well. And they're going to start holding the hospitals who do those joints with the BMIs above 40 plus and the surgeons accountable for the complications that occur because it's prohibitively high once that BMI is above 40. in respect to infections and failure of those joint replacements. Depression, 47% reduction. And that's on almost all comers, just much better resolving, improving. Stress incontinence, 44% resolved. PCOS menstrual rate, 100% improvement, right? We are able to communicate between the ovaries and the uterus. 72% resolved for gout, migraine, significant improvement. Non-alcoholic fatty liver disease, 37% resolution, but stalling the progression to fibrosis and end-stage liver disease, which has pretty much surpassed alcoholic end-stage liver disease, obesity, non-alcoholic fatty liver disease. Cancer, I just put this up there because this is theoretical. 20 to 30% reduction of risk for cancer. It's not, there's a lot of literature being published, and this isn't even in bariatric articles. In my general surgeon news article, there was something given to the general surgeon to say, hey, there's a 20 to 30% increased risk of cancer across the board for the most part in our obese patients, right? Doesn't matter what it is, esophageal, breast, pancreatic, right? And it makes sense because the obesity is a hyperinflammatory state in the body. It makes the body more inflamed. Inflammation leads to cancers, right? Patients who suffer from alcoholism, drinking a lot of heavy bourbons or smoke a lot, what happens to their esophaguses or their tracheas? They get cancers in their throat, and they do chewing tobacco. It's all the inflammation from the alcohol tobacco. Well, same thing with the adipose tissue in the body. So bariatric surgery has a risk of death 1 in 1,000. To compare this to other operations, it's much lower, right? Gallbladder surgery, 7 in 1,000. Of course, we get the opportunity to work up our patients, but there's a lot of elective gallbladder surgery too. But we do work up our patients. We get 3 to 6 month relationship with our patients. We do cardiac risk assessments commonly. You got multiple team members taking care of you, looking out for you. Trust me, sometimes we need to double check the surgeon, right? So there's a lot going on there for our population. I think attributes to this. I bet a couple people in this room have had gallbladder surgery, right? So it's safer. Hip replacement, 9 in 1,000. Coronary artery bypass, 20. And then when you think about the mortality risk per year without surgery is about 4.5% per year versus 1% per year after one has surgery. So you decrease your risk of mortality just on an annual basis by about 3.5% or 3.5-fold with the operation. So avoiding some side effects in the early post-operative period, we'll give you a bunch of information in respect to how you'll advance your diet slowly if you decide to have the surgery. We start with mostly a liquid diet, hydration, protein. We'll be like hydration, protein, just pounding it into the patients. Those are the priorities in your vitamins. And then from there, we advance you on a puree to soft to a normal regular diet, just of bariatric proportion. Taking your vitamin supplements, right? Seems easy. And for the most part with our patients, they follow it, but it's not uncommon for patients who had been lost to follow-up or who had bariatric surgery 10 to 20 years ago where we had general surgeons dabbling in bariatrics, not appropriately educating their patients, not having a system for them to be followed up. And it's not to the patient's fault. Not uncommon though, patients' surgeries in the early mid-2000s come in and they haven't seen anyone, they haven't had any vitamins, and they have some issues that we have to address. Gallbladder disease can happen in our patient population because of the rapid weight loss. It can cause stones to precipitate out in the gallbladder a little at a higher rate. But the fact of the matter is with gallbladder disease, which everybody should know, 20% of the population have gallstones, right? And of that 20%, only 20% of them ever actually have a problem with their gallstones. We know that because in post-mortem studies, there's a lot of stones in our cadavers, right? So just because you have gallstones doesn't mean a surgeon should be taking out your gallbladder. You got to have symptomatic gallstones, right? And we seem to be always more aggressive early on in surgery. We were taking everybody's gallbladder out with bariatric surgery at the time of the operation, right? Actually, when I trained, even 5 years ago, finished my fellowship, one of my attendings did it and the other didn't. But now it's pretty common we don't, because in actuality, there's a lot more literature as we track that showed there were more complications from taking the gallbladders out on everybody when you tracked how many issues than there were if you just let the disease present itself in the smaller population of patients that it would and just address it at that time. So the good news is with all these studies, it helps drive us things that are safer for patients because everything has risk. There's a risk to benefit for everything. Anything in life, crossing the street, there's a risk to benefit. Coming here to this presentation, there's a risk to benefit, right? Excess skin, that's a good problem to have, I feel like, because at that point the patient's lost a significant amount of weight. You'll get a lot of skin down here, we call the pannus, P-A-N-N-U-S. Women have pannuses too, you know. Okay, paniculectomy, right? So the pannus down there, what we'll do is, you know, a lot of times patients gets that fold gets more extenuated. In the summer times, they get some itching there, some rashes. I'll treat it with nystatin powders. And around 18 months is when I send you to the plastic surgeon. I do a pretty good job of documenting this for the patients to where a lot of times they get the insurance to cover that tummy tuck for the patient or the paniculectomy. Dumping syndrome, you know, this is kind of a blessing in disguise sometimes, because especially it happens more commonly in bypass patients. Can happen in some sleeve patients, but more commonly in the bypass population, where, you know, basically you have this small pouch. Let's say you go decide now, hey, I'm going to have that Frappuccino, right? Well, a member of the stomach has anatomy where it has a pylorus. That pylorus opens and closes and slowly releases things into your bowels. Well, your pouch doesn't have a pylorus, so you drink the Frappuccino, it goes straight into your small bowel. And it overwhelms the small bowel with a high osmolality. If you remember back to your chemistry days, osmoles pull water towards them. So when you have dumping syndrome and you take that really simple sugar type, something you really shouldn't be eating anyhow, it's going to pull the water out of your body and just flush it right through, and some pretty explosive diarrhea potentially, right? So a lot of times this can be managed just by not eating things you shouldn't be eating maybe. But sometimes patients can find that they'll get dumping syndrome with things that they should be able to eat. And so then you just kind of have to manage it. We manage it with you. We figure out what it is. We tweak the diet a little bit. And most oftentimes we can get it kind of settled down. Okay. Outcomes and complications. Again, kind of overall weight loss, about 70%, 60%. So a little higher weight loss overall in the bypass group as compared to the sleeve group. Hospital stays, this says 1 to 3, but gosh, overwhelming, and Ann can call me out if I'm lying here. 95% of my patients went home the following day, right, after the operation. Patients are pleasantly surprised in respect to how much weight they have. I'd say maybe half of my patients use the oxycodone. We have an early recovery after surgery protocol in place where we don't just plan on treating the pain with oxycodone and narcotic alone. We put our patients on gabapentin prior to surgery. We put them on like Celebrex after surgery, as well as Tylenol scheduled, and you need the oxycodone less. Some don't even need it at all. During the operation, we put a transverse abdominis plane block to block your pain from those incisions the first 48 hours or so to make it better for the patients in the worst period. Surgery is always the worst the first 2 to 3 days after the operation. Then it gets a lot better. But an overwhelming majority of our patients go home that first day. So, if that tells you anything. Leak risk is low. It's about 1% risk, right? It's an inherent risk of the operation, right? We do everything we can to, when we do surgery, to set the tissue up. In a way, I tell patients sometimes when I'm consenting them, surgery, you can kind of think of it as almost as assault in a standardized fashion. I mean, if I'm really trying to get through to a patient that surgery can be serious sometimes, it's like, I have to stab you 6 times to do this operation, right? Putting these trocars in. It doesn't sound great. So we want to make sure we're doing it for the right reasons, and we're careful, of course, when we do it, but you're still causing a little damage to get that result, right? And when you do the stapler device and you put everything together, there's only so much control you have when you dissect out the tissues and put them all together. And again, 99% of the time, everything goes fantastic. But at the end of the day, when an operation is finished, over the next 7 to 10 days, the body's still got to heal and seal it while those staples and sutures are holding everything in place, right? So any surgeon that tells you there's not a risk, there'll be no leaks, they're lying to you, because it's just an inherent risk of the operation, right? But what I can tell you, and Dr. Wang I can tell you, is if you were to have a complication such as this under our hands, we're going to see you through it, right? We're not going to transfer you to some academic center with maybe an absent-minded professor and a couple of fellows and residents taking care of you, where your family's got to travel hours to see you. We're going to take care of you. If you have an issue in the middle of the night, I don't care if it's operative or not, I'm going to come into the hospital, I'm going to see you. You're not going to have some resident, some team member, some person you don't know. It's going to be me, right? Just like NSYNC, I guess, huh? Okay. So, other issues, DVTs, blood clots. We put our patients on blood thinners. Didn't get much on the NSYNC, right? How about it's gonna be May? Okay, blood thinners, like, you know, we put our patients on heparin prior to taking back to the OR to decrease their risk of blood clots. Ulcers are more common in the bypass group than the sleeve group. And that's because ulcers can form when patients smoke, you know, particularly at where the bowel's sewn to the stomach pouch. So one thing we do require with all our patients is that they stop smoking during the program. We won't take anybody to the operating room that's as a positive nicotine or cotinine lab, and we do check them on a couple of occasions. But we'll work through it with you to get you off the cigarettes. And you got to know, if you move forward with these surgeries, that's just over. That's a phase of your life that you're past, which is certainly going to be a good thing for you and your health. Strictures can occur most commonly, though, with those ulcers at that where that small bowel is sewn to the stomach, more commonly in the bypass. Not very common in the sleeves, but they can occur, and most of the time they can be treated with dilations endoscopically. Obstructions, again, both are abdominal operations, so small risk of obstructions, bowel obstructions. An overwhelming majority of bowel obstructions, 90% plus, can be treated non-operatively, just with a little bit of, even at home, if you see it in clinics, in your home with a particular bowel regimen, or sometimes in the hospital with some non-operative medical management. Failure for weight loss is about 10%, right? So this is patients who, you know, basically develop unrealistic expectations, which in how, and we try to kind of treat this and manage this prior to the operation, right? I don't feel like our program has 10%. I think we do a better job than the nation's doing, I guess, for the average. But you got to understand, it's still, again, different lifestyle, right? Different mentality overall for that different body, different health in the long term. Risk of death is, again, very low for both. Similar kind of to the rate of risk of anesthesia. So, you know, preoperative evaluation, the first part is done, actually. You've attended this kind of information session, learning a little bit about obesity in general, about what treatment options we have, about the surgeries we have. So that's kind of checked. So now you're at a point where you could decide to come into the clinic for a consult with both myself or Dr. Wang, if you'd like. Or maybe you decide, after what you've learned, I'm not quite ready for surgery. There's no problem there. If you're not ready for surgery, you can come see Ann Kroger or Tori Sorice in our medically supervised weight loss program. We have a 6-month program. They do a fantastic job where we can use just their counseling alone and that accountability and follow-up for success. We also have a metabolic analyzer where we can give you what your actual metabolic rate is to help guide you further on your dieting and have you have more success, hopefully. And then we also have medications that we can use in that program. And then let's say you're doing that program, but you're not quite where you wanted to be, or you wanted to lose more, you can always come back to the surgery arm, and a lot of times you've already accomplished most of the things that were needed in the surgical workup, and you'll get to surgery a little sooner if you decide to take that path. But it's really up to you, the patient. And you know, we're not a program that just does all sleeves. There's a lot of those programs, but I don't think they're really serving the best interest of the patients, because in my opinion, not every patient should get a sleeve, right? I mean, the bypass and the sleeve, in my opinion, are a necessity for any genuine bariatric program, because patients with severe reflux really shouldn't be getting a sleeve, right? A patient with a BMI of well over 50, 55, 60 with diabetes should really probably strongly consider a bypass, okay? Just in general, when you look at the data or resolution, what we're really looking for here. Again, we're looking for, and what we are genuinely looking for, and I think you'll find in our program, is that we're interested in the second half of your life. We're not just interested in getting you to the operating room, you know, getting you to have massive weight loss in the first year, year and a half. Okay, we're looking at the rest of your life. And so hopefully as you kind of meet the folks in our program, you'll feel and understand how genuinely we are in that approach, and why I think over time we'll show that we have better results. Psychology evaluation is required by most insurance companies. It's also part of us being a center of excellence, so we'll do that. We have support groups that are there to support you. We'd like you to attend at least one while you're in the program. You'll find these are pretty helpful, actually, I think. And we'll help you clear the insurance, and then we'll get some baseline labs. We do an endoscopy or sometimes an upper GI to work up the foregut prior to the operation on our patients. This here we've kind of covered. Again, I don't think we need to worry about the insurance so much because we have a team in place. You'll meet maybe Renee or some other team members that'll help you kind of navigate your insurance, because a lot of insurance have different requirements. But the good news is we kind of help you meet all their requirements. We put it together in a package, and we ship it off and deliver it to them for approval, okay? So we're your advocate there. So what can you do now? I think the most important thing is, take some time to discuss this with your loved ones. I think support at home is crucial and critical for our patients. Make sure your spouse, your partner, your family is on board with you maybe taking this path. We'll help you prepare, again, your insurance documentation and make sure we have everything on board. And we'll also, when you call the office, that's then one of the next steps you'll take, call the office to set up a consult. And we'll help make sure that if you have a bariatric benefit with your insurance. Most do, but some don't. And if they don't, we'll make sure you're aware of it. And we'll give you an idea of what your options are if your insurance doesn't cover it. We want you to go ahead and start a multivitamin now, because if you do progress to have surgery, you're going to need to take a multivitamin the rest of your life, particularly a bariatric formula. Stop smoking, right? Briefly, smoking, okay? The lungs are the surface area of a tennis court, right? We all start losing lung tissue after the age of 16 to 70. It gets a little harder to breathe. When you smoke, you're damaging the alveoli that you have. You only have so many of these little alveoli. So it's going to be good and healthy for you just to quit smoking, because we're slowly losing lung tissue as we age. We all are slowly becoming pulmonary cripples, right? So when you're smoking, you're just taking away from some of those good years. Maybe you won't be able to make that walk down Bright Angel Trail, the Grand Canyon, when you finally get a chance to get there and you're 65 or 70. That'd be a tragedy. So got to quit smoking. And try different protein supplements. Even most patients come in, they're skipping breakfast. So what I would say, get some protein supplements, start having a protein shake every morning for breakfast. Don't skip breakfast, start with that shake. And start a walking program, even if you're only walking 5 to 10 minutes. Just start something, start somewhere, and progress from there. If you're having issues with the joints and you can't walk, join the Y, get in a pool. The pool takes all that weight off your joints. If you feel a concern getting in that pool and don't want to get in a class, I totally understand that. Get on YouTube, learn some different exercises you can do on your own in the pool. Get there early in the morning and the evening when it's not as busy, and do your thing. But just find some way to do it. All right. And so for more information, we can kind of refer to a couple of these websites, but otherwise we'll kind of open the floor if anybody has any questions. Well, I'd like to thank you all for coming, spending some time here tonight, and really appreciate it. I'm super humbled people take time out of their evening, and it's certainly not something I take lightly. So, if I'm your surgeon, you'll have my cell phone number when you go home from the hospital, and complete access to me with any issues, any concerns. So, thank you all very much.